Good evening everyone, myself Dr. Vandana from Patna Medical College. My case is a rare case of squamous cell carcinoma of left eye presenting to our tertiary care center. My case history is a 65-year-old male from Chhapra, Bihar came to our OPD of Patna Medical College on 1st July 2022 with the chief complaint of pinkish white mass in outer aspect of the left eye, watering, foreign body sensation, decrease in visual acuity since last 6 months. No similar complaint in fellow eye. History of present illness. History of progressive increase in swelling in left eye for last 4 months in outer aspect of the left eye associated with painless gradual diminution of vision in left eye, associated with mild pain which is limited to left eye, non-radiating in nature, associated with redness. Past ocular and systemic history was within normal limit. No history of similar presentation in family. Personal history within normal limit, non-smoker. Occupation by farmer and vegetarian. General examination within normal limit. No preocular, submandibular, deep cervical lymphadenopathy was present. Ocular examination. Right eye, visual acuity 618 with pinhole 612, near vision N12, best corrected visual acuity for distance 6/9, near N/9. Rho+ was negative. Left eye, visual acuity 6/36 with pinhole 6/18, partial and near vision 1 N/12. Best corrected visual acuity 6/9 partial and near vision N9. Rho+ was negative. Slit lamp examination. Right eye was within normal limit. Left eye have positive findings are conjunctiva mass on temporal aspect, conjunctival congestion, feeder vessels were seen. Cornea nasally clear, temporally mass encroaching to the pupillary area. Description of conjunctival growth. The growth was measuring 20 mm into 18 mm, oval in shape, gelatinous surface, well-defined margin, pinkish white in color, non-tender, firm in consistency, fixed. Located primarily in temporal quadrant of the left eye, overlying the limbus and encroaching to the pupillary margin, involving the temporal quadrant of the cornea around 3 mm. Dilated fundus examination. Right eye, media, disc, peripheral retina, macula within normal limit, left eye also within normal limit. Provisional diagnosis. Left eye, non-pigmented ocular surface, squamous neoplasm. Now differential diagnosis. The differential diagnosis of OSSN includes pingicular, pterygium, chronic unilateral conjunctivitis, pyogenic granuloma, malignant melanoma and nevi. Investigations. Anterior segment OCT. Here we see abrupt transition from normal to abnormal and hyperreflective surface and back shadowing seen and increase epithelial thickness, and this suggestive of OSSN without deeper involvement. Here is the case summary, and now coming to treatment. Excision of the growth with 2 mm corneal part, 4 mm conjunctival part outside the tumor margin was carried out, removed with no touch technique. The incision was carried through the underlying tenon fossa until the sclera was exposed to the full thickness was sent for histopathological examination. Ballpoint cautery was applied to control bleeding. Primary suture with adjacent mobilization of conjunctiva by interrupted absorbable 6-0 suture. The patient was treated with topical antibiotic moxifloxacin 4 times a day, corticosteroid for 2 weeks and anti-metabolite, then followed at 3 to 6 months interval. Unfortunately, we don't have the picture of surgery, so we draw itself. Post-operative, here is the feeder vessels and 20 mm into 18 mm, 4 mm taken from conjunctival margin and 2 mm from corneal side, and wound closure with 6-0 absorbable suture. Post-operative day picture, second post-operative day picture. Vision was 6/36, uncorrected visual acuity, and conjunctival congestion was present. Histopathological examination show biopsy showing nest of squamous cell arising from the squamous epithelium and extending into the subepithelial tissue. Keratin pulse were seen. Here is the histopathological, and here we saw in left hand side keratin pulse, and here is the subepithelial extension. Follow-up. After histopathological examination, we prescribed mitomycin C 0.04% 4 times a day with punctal occlusion for 1 week on and 1 week off basis for 3 to 4 cycles. We followed every weekly for 1 month. After that, monthly for 3 months. Patient doing well on every follow-up. No further growth was seen. Vision at last follow-up 6/9 partial, but we lost follow-up after 3 months. Discussion. Squamous cell carcinoma of conjunctiva is a rare carcinoma, more common in middle-aged men. The incidence depend on the geographical location. 0.02 per 1 lakh, high latitude 3.5, 1 lakh at low altitude. This shows positive correlation with UV rays. Multifactorial in etiology, HPV 16 and 18, various chemical carcinogens and HIV infection may play the role. The tumor appear area closest to nose and temple can coexist with pinguicula and pterygium. Main barrier for prevent invasion is Bowman's layer. Rarely the lesion appear in palpebral conjunctiva. Long time may spread into globe and orbit. The treatment options for conjunctival epithelial malignancy include excision of mass with or without cryotherapy, radiotherapy and topical chemotherapy. Surgical gold standard, no touch technique. If 8 to 4 clock hours or less of the limbus, basal diameter or 15 mm or less. Medical management, mitomycin C, 5-fluorouracil, interferon alpha 2B, and radiotherapy, extended beam radiotherapy, radiation therapy and brachytherapy. Recurrence rate after simple surgical excision was around 24% to 50%, and reconstruction of conjunctiva may be required depending on the amount of the tissue removed. It may include using graft of the nearby tissue for reconstruction. Take home message. Don't miss the lesion. Lesion elevated, acquired, progressive, extensive, fixed to underlying tissue, feeder vessels were present, must suspect for the OSSN. OSSN in young patient must rule out the HIV infection or any immunocompromised state. Appropriate early management and follow-up is important. Management need to be tailored to the individual. Thank you. And